This mic actually has very good capabilities. And I think we started. My housemates are getting ready to go out. So that's why it's a little bit loud. But they'll be gone soon. Alright, let's see here. Alright.
I didn't study. I was so bad. Not good. Not good.
Okay. Let's do it. So far I've been covering, let's turn that down. So far I've been covering the basics of hematology and immunology. I did platelet coagulation, hypercoagulability, and bleeding disorders. And now I'm going to move on. Well, actually, I also talked about red blood cell and marrow measurements. I did hemoglobinopathies and thalassemias. I did megaloblastic and microcytic anemia. And now I'm going to move on to the hemolytics. So, hemolytic anemia. My voice is starting to get a little bit tired, so I'm more quiet than usual, but I will continue, for I have a lot to get through. Okay, so let's talk about non-immune hemolytic anemias, right? So the thing about non-immune is that just like immune, you can have extravascular and intravascular, where either your macrophages are eating up your red blood cells and increasing your bilirubin and urobilinogen as well, or you'll have intravascular hemolysis, where you'll have haptoglobin. Haptoglobin is made for sequestering hemoglobin in order to protect you. And so your haptoglobin will go down because it's binding together all of this hemoglobin. You have high lactate dehydrogenase. High hemoglobin hemosiderin, which I guess makes sense because you're removing that from circulation. I'm not sure why you have high lactate dehydrogenase. That's something I'll have to check on in the future. And so there's a variety of causes for this. There's extrinsic, we can talk about first, either chemical, and we have something going on in the blood. Maybe we drink too much water, and there's toxicity from that, causing hypotonic solutions, lysing cells. Clostridial toxin as well could make your blood very hypotonic. Right? Clostridioides, C. diff causes inflammation, which somehow leads to anemia. It looks like not too sure actually about how C. diff causes non-immune hemolytic anemia. But I'm assuming it's a toxin that just directly lyses maybe vessels in the cells in the blood. There's physical immune hemolytic anemias, and that's a separate concept. You could have physical burns and radiation trauma, and you could also have an intrinsic defect, which includes a variety of options, right? You could have a hemoglobin defect. So essentially, it seems like anything that creates a cell that's abnormal or doesn't pass the bar will get phagocytosed and may have spillover when severe. So low hemoglobin production or dysfunctional hemoglobin in your thalassemia or hemoglobinopathies would lead to anemia. It could also be an enzyme problem. So the pyruvate kinase deficiency, what that involves is you don't have enough ATP in your red blood cells. And I mean, that makes sense, right? This is the one of the last steps of glycolysis. And so if you don't have that, then the result is that your blood cells are going to die. Well, I mean, they don't use a lot, but they're not going to have energy. So what's the problem, right? So why do they die? They break down faster. Maybe it's because they can't repair themselves. ATP is important for regulating spectrin, as you can see here. So not having it, so even though red blood cells don't have nuclei and don't do a lot of synthesis, not having enough ATP can still, they still have some functions where they try to regulate themselves, you know, and so without it, they could have further damage. So that's the reason for that. And then you could also have oxidative damage, which is in G6PD-H deficiency, which is important in the pentose phosphate pathway. That's how we produce NADPH. So if you don't have NADPH, you can also have damage. So both of these are really mechanisms that will increase the rate of damage to the cell, whether it's lower antioxidants or it's lower repair or lower regulation mechanisms. So this might result in bite cells. Heinz bodies are, you can get a photo of a Heinz body. It will look a little bit like the sideroblastic, but it's a lot more dotty. And it might even look a little bit like the Howell-Jolly is what I was going to say. So how do we compare Howell-Jollies, right? Those are Heinz bodies versus Howell-Jollies. I think the main issue is the color of the staining. So on the left, Howell-Jolly, and then that one's Howell-Jolly, and these two are Heinz bodies. And I think it depends on the stain as well, because this can be seen with a normal stain. That one requires special staining. In any case, they're going to look a little bit weird because they can't save themselves. You also have a special genotype. This is how you get the deficiency, GDA minus. And that low NADPH causes lower glutathione. Glutathione is important in H2O2 removal, oxidation of H2O2, because it has the thiol SH, and that's like the cofactor important in reducing the H2O2. And apparently this is not something you'll see normally, but when you expose it to an oxidant, then it starts to show. It can happen pretty quickly. You'll have anemia, dark urine, jaundice, distended renal tubules. So far, the only thing that we've seen that's pretty similar to the challenge, maybe, is the hemophilia. Sorry, not hemophilia. We're talking about sickle cell heterozygote. But that's different because that one is O2, and then this one's a challenge of oxidant or pH. That's when you have oxygen damage. It's a little different. And you can also have membrane defects. So this can cause these two, which is a problem when you don't have a strong membrane. Right here, the spectrin won't form tetramers, so you'll get ovelocytosis, which sometimes gets you splenomegaly. If it's more severe, you see here, you have less inchirin and maybe also low spectrin, so inchirin is really important, where you probably have the lattice, but it's just not attached well to the membrane. So that will cause the spherocytosis, like very bad swelling, and lipid loss from the membrane. And those will easily get stuck in the spleen. This is tested by the osmotic fragility test. You just put it in some hypotonic solution and it should explode. Whereas other cells don't really do that because they're not like about to burst. These guys are about to burst. You push them a little and they just, and away they go, you know. Paroxysmal nocturnal hemoglobinuria. These are neoplastic red blood cells. So far we've been talking about just abnormal in the sense that there's like a mutation. It's not causing neoplasm or strange growth. It's just they look bad. These neoplastic ones are missing. They have a few different kinds of mutations. And so they're missing a few of these things. This phosphatidylinositol-glycan A. So this PIGA if it has a deficiency in PIGA, it's something that controls. All these are things that control the red blood cells from growing too much, and so these are a few of the mutations that happen. Loses CD55, loses CD59, and then it gets it undergoes hemolysis because of that. So it's just bad cells. Apparently all the cells die. All types of cells die, which I don't really understand. I suppose these are on a variety of cells. We can take a look at that. So it's a membrane defect. So if you're missing pig A, as I've shown here, you're also missing CD55 and CD59. And okay, got it. So if you're missing both of these, then the complement is able to lyse. Whereas normally, DAF and MERL, 55 and 59, are able to repel complement from breaking your cells. So that's what that is actually. So neoplastic is not in the sense that a lot of them grow. It's neoplastic in the sense that it has some mutations that causes this sort of lysis. So you had to transfuse it with washed red cells in case your new complement lyses the existing red blood cells. So you gotta watch out. Okay. That's not immune. A lot of inherent cell problems, either in red cell ability to maintain itself, ability to maintain its membrane. All of this is maintaining its membrane. Integrity, whether it's defending against the immune system, whether it's the tonicity of the fluid, whether it's oxidative factors, it has to protect itself. And it needs ATP and ADPH. It needs defending cytokines. It needs strong ankyrin. And if it doesn't have any of those, it will lyse and it will get eaten up. So that's non-immune. All right. So we've looked at non-immune. We could... Let's look at immune. Even though we haven't gone through immune system yet, we can talk about the hemolytic anemias. So, for this... So, as we've discussed earlier for the Coombs test, if you have a hemolytic anemia of the immune kind that's happening, you are always going to get a positive Coombs because the antibody is already on the cell. Simple as that. And this kind of reaction can happen because of drugs. It can happen because of transfusions. But it could also be autoimmune in origin. Either due to some sort of neoplasm or virus or a bacteria. So we're going to start by talking about drug reactions that cause immune hemolytic. No, I'm talking about that last because we need to go through these first. Let's go through transfusion reactions. So, if you have an ABO blood type, that's wrong, or an RH blood type, that's wrong, and we'll go through this more a little bit later. You're going to get hemolysis. If it's IgG, you need 2 IgGs to be positioned perfectly right for your complement to then latch on. So lysis is rare, and you're more likely to opsonize and phagocytose. Whereas IgM, you'll need 1, I'm pretty sure. So your lysis chance is much higher, and that's the primary method, is intravascular, inside the vessel. So you have like an allergic reaction, is how it'll look. And there's some risk factors, and we'll cover this a little more in a very specific part. Okay, next we're going to talk about warm. So when we talk about warm or cold, what we're talking about is the temperature that the antibody binds best. It's not about when the complement forms best, it's about when the antibody binds best. So warm will bind at the 37 degrees, and it can be caused by these right here: infection, autoimmunity, neoplasm, all possible. The B lymphomas are implicated specifically because obviously antibodies, right? And so for warm, these are both of these are more common in women as well. And both of these are towards themselves. This isn't anything about newborns. This is sort of an autoimmune thing. Over 40 years, over 50 years, I mean, that doesn't make such a big difference, I guess. So, I mean, your demographics are still, I mean, you're still just women over 40 years old, right? I mean, you could say cold is more common after that decade. But the mechanism is primarily IgG. So you'll have a lot of phagocytosis, which causes this splenectomy. Pretty normal for extravascular. And in order to make up for that, you'll have a lot of reticulocytes. You'll be on overdrive in making red blood cells and also in breaking down red blood cells. You have spherocytes, because sometimes your spleen will try to chew it up, but it won't do it successfully. So you have these partial red blood cells. And your marrow is obviously overworked. So you could help solve this with some immune suppression. Hopefully the red blood, your spleen is gonna not recognize it as much and not be as active at taking these out. Because I mean, all of this, if we talk about it, these are all functional red blood cells. These are normal-ish red blood cells. The main problem is the immune system's just mean to them. So anything you can do to keep the immune system nice to our red blood cells will keep them working. They want to work, and they work well. Meanwhile, for cold, we bind at a colder temperature. And so what happens is in the hands and the feet, it'll bind, in our extremities. And then when it comes closer to the body, it's going to lyse. And that's a problem, right? Yeah, I don't know if the fact that it's lower than 37 degrees is the cause of this difference in this addition of IgM in the mechanism. It could be, but in any case, the cold hemagglutinin disease is a result of the IgM. Which causes a finger discoloration. If we can get a photo. Sort of bluish fingers. Oh, that's it right there. So bluish hands. And so it'll agglutinate. It'll be anti-big I. So we can talk about the I, little I, ABORH, just in a minute. And so even though it's IgM, you have some phagocytosis. On the other hand, IgG is called paroxysmal cold hemoglobinuria versus cold hemagglutinin disease. So I need to check if I wrote this wrong, because IgM should not be lysine. So as we discussed, IgM is mostly extravascular in this case, which is kind of strange. So interestingly, this one is phagocytosis mostly, because the IgM falls off. But the IgM was successfully able to bring the C3b on there, so it's not enough to lyse it, but it is enough to opsonize it, which is kind of fascinating. Whereas paroxysmal is IgG, so you'd expect extravascular. However, for some reason, it's able to lyse. So this sort of flips our concepts on its head a little bit. And I think it has to do with that special cold to warm interaction. But instead of doing IgM phagocytosis, IgM lysis and IgG phagocytosis, it's flipped. But of course, they both have some lysis. I guess cold hemagglutinin is, the main thing is the agglutination, right? And so it has that finger discoloration, whereas paroxysmal is mostly lysis. So we got to think about that a little bit. Donath-Landsteiner is a type of antigen, P antigen. So I don't think that's a blood group that we learn about later, but I antigen, I'm not sure. can talk about the eye antigen. Take a look here as well. Okay, so drug associated is going to take what we learned so far and take it further. So there's a few models depending on which kind of drug we're talking about. If it's penicillin and cephalosporin, then we use the Hapton model, which is where the drug attaches to RBC and then the IgG attracts to the drug. So these have antibodies directly on them, which causes phagocytosis. If you think about that, that makes sense, right? The next is the complex, which is related to quinine, quinidine, cephalosporin again, and phenacetin. And so that will have IgM. And if we have a photo, I don't think the photo really helps, but somehow this helps form the MAC. You get C3b all over, and then you get the full-on C9 pore that will kill the cell. Interestingly. And then autoimmune is straight up just doesn't like red blood cells. That's like our normal ones up here, except it's not spurred on by anything. I guess it's essentially just the same thing as warm. It is pretty much just warm hemolytic anemia, right? Except it's stimulated not by autoimmunity, or not. It's not stimulated. Well, I mean, it is. You know, this is literally just the lupus example here. We have IgG on the blood cells and causes phagocytosis. So the main thing is that stopping the drug will help for both of these, but this one it won't. So I don't even think this one should be here. It's just happens to be activated by drug. We should just write drug here as a cause instead of putting here. So ternary, IgM, Hapton, IgG. So that's our anemias, hemolytic anemias, both of them. Alright, so we've covered this, we've covered that, done these, done that, and done that. We come back in a minute, and I'm going to be talking about anemias, specifically transfusions, and types of drugs you can give somebody who has low red blood cell count. So I'll be back. Okay. Honestly, my throat is starting to get really sore, and this is starting to feel like a really bad idea. But I did just get through. How much would you say? A little more than a third of the material. So, I mean, it's not terrible. I'll be back. So, what do we do for somebody who is anemic? Let's take a look here, right? So, anemias, we can either give them a drug to help them form more blood. We can give them iron, as we learned earlier with the microcytic anemias. We can give them iron. And we can also give them straight up a blood transfusion. So I want to start talking about the drugs affecting blood formation. But I could do... you know what, I'm just going to say that, but I'm going to move on first. I don't think it's time to talk about that yet, because then we had to talk about transfusion complications and the blood formation will have a lot of other cells as well. Actually, this will work great. Actually, no. I am going to do the blood formation drugs, and then we can do... Let's do it. Let's do it. I take it back. Let's do it. Okay, so for somebody with anemia, we can give them drugs to help them make more blood, or make more of whatever they're missing, right? So for red blood cells, let's talk about red blood cells. We talked about iron deficiency earlier, right? So we can give them iron. And that can be given in a variety of forms here. But it is iron, whether it's an injection or an IV, or whether it's a pill, it's iron. You have to wait a while before it takes effect, and it can cause some GI problems, some diarrhea. You can have high iron, which can make infections a risk. You could be allergic, but that's pretty rare. You can also use it for In the case of malabsorption, you can't really do oral, right? So maybe we could do a transfusion instead. If we were talking about other ways to make red blood cells, we could talk about some drugs right here. So this one right here is for making red blood cells. Erythropoietin, as we talked about, erythropoietin is normally from the kidney, but it's a signal that goes to the erythroblasts in our marrow, and it will start to make more of the erythrocytes. We're going to start the progenitor action. So if we cross-reference that real quick, we can take a look at that. If we go back to red blood cells, back to our kinetics, actually, I believe it's O12. We can take a look and see that. Well, that's not the one. I think it's probably formed elements. So you can see the red blood cells, and so we're getting our pro-erythroblast to make more erythroblasts. So more blasts. That's what that erythropoietin does. Good. So back to it, 49. So that will cause us to make more erythroblasts, which will eventually result in more erythrocytes. And obviously for anemia, side effects, you could end up using up all your iron, right? And you could end up with too many red blood cells, which might cause you to have a problem with clotting. It could increase your blood pressure because you have so many red blood cells. So the way I see it, you should probably pair these together. One to make more red blood cells and one to give you the iron to do that. So you either pair these together, give one of them, or you give them a transfusion for low red blood cells. Great. Now let's talk about platelets. We have too few platelets. And that could be due to a variety of reasons. Either our platelets are bad in our hemoglobinopathies. Oh, sorry, not hemoglobinopathies. Our platelets, sorry. Either our platelets are bad because they have missing factors, or, right, it could be due to another cause. Let's take a look back at coagulation, right? Either we have a problem with our platelets and how they're made, or they're not making it to the right destination, or they're getting consumed up and getting phagocytosed, taken away, right? But in any case, those are the three possibilities for why we might be facing low platelets. Let's say we did have low platelets, right? What would we do? So we would want to give somebody something that increases their megakaryocytes. Either it will make them grow faster, or we would want them to differentiate faster. So far the only interleukin we've learned about is IL-6. IL-6 goes for hepcidin, but now we can learn about IL-11, which increases megakaryocyte maturation. And so oprelvkin is injected, and it's recombinant, which means it lasts longer, but it should do the same thing as normal IL-11 to increase our platelets. On the other hand, we could give thrombopoietin. Yeah, I don't think we learned too much about the thrombopoietin origins. Thrombopoietin is secreted in the liver, and it helps the megakaryocytes help us form more of the myeloblasts to form megakaryocytes. And the problem with that is you could potentially, very rarely, get some cross-reactivity, and that'll cause long-term allergies to your existing thrombopoietin. So there's a bit of a risk. So again, thrombopoietin and IL-11. So we can signal the existing ones. We can make more. All these poietins all make more blasts, really, right? Erythroblasts, megakaryocytes, related blasts. So, yes, making more red blood cells and more platelets. So let's talk about if we have too many of these, right? Too many. We'll talk about that in a minute, actually. So let's talk about if you have not enough, still not enough red blood cells. We already talked about, I already talked about iron and erythropoietin, but that's only for microcytic, right? We also want to talk about megaloblastic, and that could involve your vitamin B12 and folic acid, as we talked about. Vitamin B12 causing our pernicious anemia and our neurological problems, whereas folic acid, not so. Folic acid in purine synthesis, vitamin B12, I think it does more than just purines. Folic acid, if I remember correctly, wasn't folic acid pyrimidines? Let's take a look. Here is the folic acid involved in U to T, which should be pyrimidines. So either I wrote that incorrectly or I was wrong. So apparently pyrimidines do not need folic acid. Okay, so it is involved in pyrimidines, but apparently it's also involved in purines. Go figure, right? So apparently this is not the full picture. There's more to it, which I guess is expected. But in any case, I gotta go back to our drugs. You could give folic acid or vitamin B12. And both of them are going to help you synthesize more DNA and help you out. Vitamin B12, you might also consider giving them vitamin K instead, right? Oh, sorry, no. Giving them the chelating factor, intrinsic factor. You could give them that as well. Right, where as folic acid, you have to give them folic acid. Vitamin B12, you can give them. Okay, so that's that. Real quick, I'm going to talk about if you don't have enough granulocytes. So, what are the reasons that we have not enough granulocytes? It could be due to chemo, could be due to transplant. Those are like the two main reasons. I suppose if you had some sort of megaloblastic problem, you could also have lower neutrophils and myelocytes, granulocytes. But these two are pretty similar. There's granulocyte macrophage colony stimulating, and I think this is just granulocyte stimulating, colony stimulating. So it's called sargramostim, filgrastim. So they're both stims, stimulating factors. Both of them are injections or IVs. This one's a little bit different because it's not cleared through the liver, but it's cleared through the neutrophils instead. So that's why it has a little bit longer half-life. So then you'll have more neutrophils in both of them. However, this one has more bone pain and vasculitis. So I'm not entirely sure why this one has more compared to this. But in any case, these are two granulocyte stimulators. Now that we've covered that, we can go over here. We can talk about anti-clotting. So, first I'm going to talk about oral, because obviously if you can give an oral drug, it's probably better than giving it as an injection. So, oral drug, the important one is warfarin. Warfarin blocks your vitamin K ones. So 2 is a common pathway that's called prothrombin. X is your common one as well. 9 is intrinsic, and 7 is extrinsic. So I wasn't right when I said these are all extrinsic, because it's not true. This one's intrinsic. But vitamin K antagonist, it prevents clotting factors from performing their action. It has some interactions. I don't think I'm going to memorize these. But I guess we should know that it is a potential teratogen, the warfarin. So that's kind of important. If you can't give that, right, you could give them some other oral ones. This is if you have some problems with warfarin, either the interactions, side effects, or otherwise. And most of these are good for prophylaxis. So you could block thrombin factor 2 with dabigatran, or you could block factor 10 with any of these, rivaroxaban, apixaban, edoxaban. You could also look into parenteral if oral is not as good. So heparin is the big guy for parenteral, and heparin, we had to think about that a while back because that could potentially cause hypercoagulability because of antibody interaction. But normally, that's going to work through antithrombin, and that's going to break the existing clot. So you can use it for a variety of existing clots. Obviously, bleeding is a side effect, but here's the heparin-induced thrombocytopenia we were talking about, where it might actually increase it. And protamine is the cure for that. Protamine, I don't think we wrote about that, but yeah, but that's different. Actually, that's antithrombin. Antithrombin is different than plasminogen. This is a factor 10 inhibitor. If you can't give him heparin, you can give him something else. You can give him a factor 2 inhibitor, right? When you have this HIT, you can switch it. So you have these right here. Argatroban, lepiridin, bevaleridan. You give protein C. We learned about protein C as well, which is a natural inhibitor, such as drotagogen alpha. Yeah, these are all ones that we've learned about before, just in drug form this time. Dinaparoid is a similar as well in the antithrombin category. Let's see, is there any that we didn't cover? I can take a look too. Any coagulation factor things that we didn't talk about? Not thrombophilia. We're going to talk about bleeding disorders. Protein C, antithrombin. Here it is. Prothrombin. I don't think there's anything to decrease prothrombin. Oh, prothrombin, thrombin. Yeah, we have thrombin. We have protein C. We have antithrombin. We have both. We have all three of these. Yeah, so that's good. Factor 2, factor 10. Right. Five and 8. That's intrinsic protein C, as we learned here. So, I think 5 was. I'm going to check real quick what 5 was. Yeah, factor 5 and 10 are together. That's common pathway. Okay, so this is preventing clots from forming. But you also have this one which breaks clots. Streptokinase is the only one that really breaks existing clots. by activating plasminogen. All of these are other factors, or clotting factors. This one's fibrinogen. Plasminogen. It's going to break it, and you can have really bad bleeding because of that. So if that happens, then you got to use something like aminocaproic acid in order to counteract that plasminogen effect. So these two come hand in hand, streptokinase and aminocaproic acid. So that's basic gist of it. Low red blood cell, consider iron, consider erythropoietin, consider B12, consider folic acid. Platelets, consider thrombopoietin, consider IL-11. Granulocytes, consider your GM-CSF or GCSF. Obviously, the risk is that you have inflammation. If you want to block clotting from happening, then you want to use oral warfarin, so vitamin K antagonist, or parenteral heparin, which is an antithrombin inhibitor. So you think about those, or it's an antithrombin, which is a factor 10 inhibitor. We got to remember these extrinsic vitamin. We have to remember the vitamin K. So it's 2, 7, 9, and 10. So you got to do that, and you also have to consider how to reverse, how to break a clot, streptokinase, and how to reverse that overbleeding with aminocaproic acid. So that's the blood drugs for that. I think I'm going to save transfusion complication for when we have hypersensitivity. But we can talk about blood types. Cool. So obviously we talked about the alternative to transfusion, which includes erythropoietin, iron, folic acid. We could add B12 in here, right? And you could also talk about vitamin K. If they have a high INR, they're not clotting as easily, you can give them vitamin K. But otherwise, if its short-term need is great, we could talk about blood transfusion. So blood donation is done by these agencies. They screen for these viruses. And with collection, you could do it one of two ways. If you are trying to, I guess, be kind to the donor, or if you only need one thing specifically, you could do apheresis. So that'll take only what you need, and you give back everything else. Or you could take all the blood, the whole blood. Right, so whole blood. And so whole blood you can spin down, and there's a variety of components that you can use in whole blood. You can use the red blood cells or platelets, or you could use the plasma. Red blood cells are normally used to prevent hypoxic injury, so you want to keep the red blood cells there so that you can perfuse organs. So you could give somebody hemoglobin, even though they have you could give them red blood cells even at a high hemoglobin if they have thalassemia, because their hemoglobin is not good, right? Um, and you can maintain it if it drops in other cases as well. For platelets, they're either non-functional or you have too few of them, right? So if they're non-functional, it can be due to drugs or a genetic disease, as we learned von Willebrand's, the anchor point, Bernard Solier is the anchor, Glanzmann is the friends, and gray platelet is a special case where there's no aggregation because the alpha granules are few. So that would be your fibrinogen in there. You could also give platelets if there's too few, and that could be due to dilution, which is when you give somebody too much IVs or you give them too many transfusions that lower your concentration, or they could just be clotting a lot, and that could be consumed. You could also have a marrow failure, which there's different thresholds that you start giving it. So if it's a neurosurgery procedure, I suppose for anything neuro, you want you don't want any bleeding to happen. So you really got to give a lot. Major surgery, a lot as well. But it goes down to 10,000. And sometimes what will happen is just no matter what, the platelets will still be low, even though you gave them platelets. So why might that be? It might be because the spleen is eating it up. It could be because of it could be due to the antibodies attacking it, or it could be consumed from DIC. Sometimes the problem is not a problem with your platelet count for clotting, but the problem is the clotting factor. That could also be diluted. You could have the warfarin overdose, too much warfarin, or too much of any of our mentioned clotting anticoagulants could all do that. And so in order to restore your clotting factors, you could give them either fresh frozen plasma, which has everything, or if you know which one specifically, you could give factor concentrates, such as factor 8 for hemophilia A, or fibrinogen, right, if they need that. Might even be better. So if they're not bleeding, check warfarin. Warfarin is, I guess, a big one here. And if vitamin K is an option, honestly, that's the best, right? You could give prothrombin complex concentrate. It's factor 7, a lot of factor 7. And neurosurgery requires a lot, as we were saying as well from earlier. So, yeah. And then we got to think about what kinds of people we can transfuse with what blood. Okay, so in order to test that, we have our Coombs, and we're going to talk about this more in a minute. But there's a lot of blood groups. It just so happens that the main ones that we care about are ABO and RH. ABO being what we have on top of the H oligosaccharide on a red blood cell, whether it's a galactose for B or an N-acetylgalactosamine for A. In any case, A's and O's are the most common blood types. AB is the least common. And for ABO, it's IgM hemolysis. And we'll talk about this in a minute as well, but it appears to be more severe for ABO as opposed to RH mismatch, which makes sense why we care so much about ABO. RH mismatch. So RH, actually, there's a lot of different ones, but we mostly care about RHD. RHD, which is most people are positive RH factor. But if you infuse somebody who's negative RH with a positive RH blood, you get IgG. Believe it or not, there's actually a few other systems as well that are less common, such as Kel. And Kel is pretty rare because having one of these, like having Kel 1, is pretty rare, 10%. Being homozygous for that is like 1%, right? So it's pretty uncommon. But in the case that you do have a patient with anti-K, anti-little k, then you will have some pretty severe disease. Kid, usually not much of an issue. But again, it can cause problems. Duffy, you have to be double negative to have the problem, but I'm going to compare the severities. So obviously ABO is bad intravascular hemolysis. RH is a little better. It's extravascular, right? But I guess the best way to put it is ABO is the most severe in the patient. But if we're talking about the newborn hemolytic disease, that's the worst for Kel, because it's on the precursors, whereas the rest of them are not. So Kel is going to destroy like everything, whereas the other ones will cause damage but not as bad. And that also tells you that RH, Kel, and Kid and Duffy can all pass the placental barrier, right? ABO, I don't really know, but that's the situation for that. Yeah. Main thing is Kel. Kel is big bad for newborn. Yeah. All right. Let's see if we can talk about transfusion complication. So this one will have a little bit more about the it goes into hypersensitivities. So I'm going to wait on this a little bit. But we have talked a lot about it already, right? We've introduced the Coombs and everything. We'll come back to that. So after this, I'm going to talk about innate immune system. All right. Okay, so let's continue on to innate immune system. This should be pretty quick, actually. And I'm going to cross-reference my old notes as well. So there it is. So we're going to look at the cells of the innate immune system. So we have our innate. So how should we look at this best, right? Let's talk about first our favorite cell when we talk about innate immune system, and that's our natural killers. Oh, sorry, not natural killers. It should be our dendritics. I'm going to start with macrophages. Sorry. Okay, so macrophages going around in the body, eating what they can, and how they do that is through recognition. And if that's the case, maybe it's best that I talk about this first. So how does the body know when something is an enemy? Right. We're talking about innate. So how does this is pre-programmed? How does the body use the pre-programmed knowledge to tell if something is different and doesn't belong? Well, it uses what we call pathogen-associated molecular pattern called a PAMP, and it has a lot of different little sensors that can tell if something is different, doesn't belong. The classic one is the toll-like receptor. And the toll-like receptors has two different parts, as a recognition part and a signaling part. And it terminates in the NF-kappa B. So we can talk about NF-kappa B in a little bit as well. When we talk about immune system in general. Right here, O10 immune system. Now that I'm looking at it, I'm starting to feel that we'll just continue. Sorry. We'll continue with what I said. Start with innate recognition. But there's a few different kinds of these toll-like receptors, the TLRs. There's some that can live in that are inside of the cell, so it'll detect something that is inside the cell. And so there's 3, 4, 7, 8, and 9. Those do inside the cell. And then there's also ones that are on the outside of the cell, so it'll detect if it meets something bad. And that's 1, 2, 4, 5, 6, 11, 12. I suppose chances are, if it's like a nice rounded number, it's probably extracellular. But it's hard to remember. I don't think I'm going to spend time remembering these. There's the nod-like receptors, which are very similar to the toll-like receptors in the sense that they both have these leucine-rich repeating regions. But it's a little bit different in how it signals. Instead of using the dimerization, instead it uses this caspase 1 pathway. And I'm also going to talk a little bit more about these cytokines, but there's a lot of them. And we're going to look back. When we look at cytokines, we're going to look back and forth, just so that we can try and figure out which one is which. So, next we have C-type lectin. Lectin is something that we've seen earlier, but essentially it's on the outside of a bacteria carbohydrate, and it will get recognized. So there's a few different kinds, but essentially if it detects carbs. Scavengers detect lipids, SRA, SRB, lipopolysaccharide, teichoic acid, lipoprotein, right? All of these. Scavenger receptor, if I remember correctly, was also involved for cholesterol metabolism. So I'm not sure if there's a relation there, but there could be. Lipopolysaccharide is on gram negative. Teichoic acid gram positive. I don't know if I don't have the photo of the gram negative and gram positive. But I don't know if it's worth the time to look at the difference. There's a pretty good image actually. The gram positive has single layer, and it has a ton of lipoteichoic acid, as we're talking about here. Whereas gram negative has that double layer of membrane, and then it just has lipopolysaccharide, LPS, up here. There's also Rig-like receptors for RNA, DNA receptors for DNA, obviously, and protein receptors too, and formal. So this is probably some moiety that it often detects on a bacteria, and it has this one as well. We also have opsonins. So that'll detect your complement, for example, or your antibodies. So there's a lot of variation: protein, DNA, RNA, lipids, carbohydrates, and then these are more diverse, not until like. But essentially, we want to detect something foreign. And then once we've detected, we're going to put out some response, right? There's these peptides floating around, lysozyme that are inside the granules, opsonins, defensins. There's a variety of cytokines that we really need to know all these cytokines a little bit later. But so far we know about IL-6. IL-6 is involved for that fever, and it's also involved in hepcidin. IL-11 we learned already, but it's not here because IL-11 is for megakaryocytes, so it's not inflammatory. But we see all these other interleukins. TNF alpha, IL-6, these are all pro-inflammatory. T helper is IL-12 and 18. We're going to have to come back to this, obviously, because I have no idea how to remember that. By APCs. And then IL-10 is for macrophages. We'll come back to that. Chemokines. There's a variety of these. There's chemokines to help the B cells get to the mucosa where they can put their IgA out. These neutrophils follow CXCL8. We can put out interferons. Interferons are specifically for viral. So if we can see here, IFN alpha and beta right here for viral. And this is for intracellular bacterial. So all these are intracellular anyway. IFN alpha and beta are for JAK-STAT pathway. I think we're going to see a little bit more JAK-STAT in a minute. And IFN gamma is for macrophages. Complement we'll touch on later. And there's also some other stuff, which the platelets are also involved. So you could actually have clotting happen. and you could also have Keenan's or vasodilation. We're going to go into that a little more later as well. So that's the basics to signaling and detecting something foreign. And then let's talk about who's going to be doing that job, right? And that's the innate immune cells that are doing that job. There's a lot of them, but the main thing is these are antigen presenting cells. Sorry, these ones, dendritic, macrophage, and neutrophil. We talk about macrophage first. They can phagocytose, and then they can present. So lymphocytes and leukocytes specifically have the MHC class 2, whereas all other cells, all cells in general, have MHC1. So macrophages have both, and they can secrete a variety of signals to recruit. So CXCL8 we were learning earlier for neutrophils. TNF alpha, IL-1, IL-6, these are our classic inflammatory markers. And IL-12 we learned a little earlier was a T cell attractant. So that's good, we know that. It can also signal the with the acute phase reactants. We learned a few of these already. We're going to see serum amyloid associated a little more later. Mannose binding lectin, see that's a signal for certain polysaccharide on the bacteria, right? The lectin we were learning about. C-reactive protein as well. There's two types of macrophages. M1 is very pro-inflammatory. IFN gamma. And then there's the M2, which is very anti-inflammatory, TGF beta. So TGF beta. And we're going to see that later as well for cancer cells like that. So after tissue macrophages, we're going to see that these guys can activate natural killer as well with IL-12. So IL-12 seems to be a lymphoid-related cytokine. It does T cells, does natural killer cells, and IL-15 seems to be the natural killer cell one. We'll come back, and you got to remember, IL-15, natural killer. And IFN gamma seems to be the big macrophage one. Anything IFN gamma, you're going to get all the macrophages. But your natural killers, so as we learned, are the lymphocytes that do innate functions. So they can make cytokines. They can do IFN gamma, as we were learning, macrophages. And then alpha and beta, IFN alpha, alpha and beta. These interferons are big for intracellular parasite, so it makes sense you would do natural killer to kill with it. I imagine these also are for cytotoxic T cells. As we can see here, IFN alpha beta is also important for the ADCC killing of the of cells that are labeled by antibodies. You could also have so when you have a deficiency, right, you're gonna have whether it's fewer natural killer cells or it's just less functional natural killer cells, you're going to have more eosinophils. Why that's the case, I don't know. Maybe it's to compensate. So, okay. And then neutrophils are our favorite. It's not our favorite. It's just our big suicide bomber little guy. Goes past the basement membrane. It can navigate real well, right? It has those the beige granules full of, well, I guess we're going to go into it a little bit, but it can go through the basement membrane. It can explode and throw its DNA everywhere. And important thing is it uses the H2O2 halide system. So first thing it makes is H2O2, which is important. It's most important. And then for that extra added bit of oomph, it does the myeloperoxidase, the HOCl. The halide. It creates a halide, sorry. Right. And so that's neutrophils. Dendritic cell, is our true favorite antigen presenting cell. It's the professional, I guess. Is our classic CDC, our classic myeloid, or our interdigitating dendritic cells. And those can be in the skin, they can be elsewhere. Plasmacytoid are a little bit special, I think, because they're like factories for IFN alpha and beta. So I suppose if that's the case, then it must have met some sort of antigen that signals an intracellular parasite, is what that must mean. Because these are all intracellular signals. They could also be, I guess dendritic cell is sort of a pretty broad class because it can even include mesenchymal cells that can train B cells, for example. Like this is important for the somatic hypermutation, and it's also important in the affinity related selection of good B cells. And then we have our favorite, the rest of the granulocytes. We got basophil and mast cell. These two are like brothers. Mast cell, obviously histamine, both of them histamine. And TNF, obviously inflammatory marker. Basophil as well. Basophil actually works pretty closely with the T helper 2s, and it does that using IL-4, IL-13. So we can look at that a little bit later, 4 and 13. Whereas eosinophils are mostly just anti-parasite. We learned a little bit about innate lymphoid cells, which don't really do anything. They're like natural killer cells in the fact that they're lymphoid, but they don't really do anything other than signal. So they're like the T helper cells of the innate, if they existed as anyway. So ILC1 for virus, ILC2 for worms, 3 for intestinal barrier. So that's innate immune cells. Actually, I want to compare this with my old notes on innate just to see if there's any differences or if there's anything that we can add. So lymphoid progenitor will have your ILCs right over here. TNF, IFN gamma. I don't know much about IL-10, but these are all involved for viral. Makes sense. ILC2 is for worms, parasite responses we can see here, and mast cell degranulation with IL-13. I didn't have ILs on here that much. (13) and 4 apparently are not just for T helpers, but also can do fever, interestingly. ILC3s for intestinal barrier and healing, right? IL-22, IL-17, 17. So Yeah, that's ILCs. We also have our myeloids. We can compare these. Neutrophils. CD15. I don't think I wrote the CD number, but neutrophil is CD15. Eosinophil, basophil, erythrocyte. We already covered those. Oh, we can do the TLRs. Actually, we can compare the TLRs real quick. Let me get that. TLRs. TLR. So 1, 2, 4, 5, 6, 11, 12. 1, 2, 4, 5, 6. I don't have 11, but 1, 2, 4, 5, 6 are all here in extracellular, just like we said. 3, 7, 8, 9. And also 4 apparently are intracellular. So that part checks out as well. Alright. Looks good. What other innate immune cells can we talk about here? Neutrophils and dendritic cells. We talk about dendritics. So yeah, this is something that we talked about that I learned a while back. I guess I forgot. Is dendritic cells can come from myeloid and can also come from lymphoid, depending on a lot of factors, but that can happen. We didn't learn about CDC1 and CDC2. We just learned about CDCs. So that's fine, I suppose. These are all your chemokines, macrophage. Know a little bit about that. But type 1 is almost always viral, right? Type 1 is, as a rule of thumb, viral. Type 2, as a rule of thumb, is extracellular. Yeah. Okay, so that's most of the innate. What am I missing? Complement. Great. I like complement. So, complement. Complement. 3 pathways of complement. We have lectin again also. Lectin. But here's the 3. And I put it in order of how fast they're supposed to be. So alternative is technically fastest, then lectin, then classical. Alternative is the outlier here, whereas these two are more closely related. Because alternative is sort of weird. It sort of activates on its own. As you can see, the C3 factor B is cleaved in water. And B's cleaved by D. And then this is BBB. There's just like a ton of B's. That's alternative. And then this creates a lot of C3A, right? And C3A is something that attracts your mast and basophil, so your histamine cells. And also opsonizes for phagocytosis. That's the big deal with 3B. Interestingly, there are some things that inhibit factor C3b, factor H, factor I, and then interestingly we have these two guys, DAF, and later we're also going to see I think C1 inhibitor as well. Let's pull it up, right? Because we had the hemolysis of red blood cells. We can compare now.
Time to wrap up.
Nope, it's going to crash on me. Ooh. All right. We talked about red blood cells dying on us in a non-immune hemolytic, so let's open 22. And that's when we have not enough DAF and not enough MI Merle, I believe. CD55 DAF and CD59 Merle. So we have DAF here, right? See that? I don't think we have. Membrane inhibitor reactive lysis. We don't have Merle. Well, we have DAF, right? So DAF will inhibit that and protect your body's cells. So will MCP. H and I also do the inhibition. Almost all of these are inhibitory except for factor P, which I don't know much about factor P, but factor P will improve your complement opsonization. So, yeah. Let's move on to lectin. Lectin happens when you have the carbohydrate. That's the bacteria surface. And versus classical, which is IgM, so this is antibody mediated. So this is more of a direct recognition versus this one's an antibody recognized. And so mannose binding lectin is just like C1q. They both start something. And then MBL and MASP right here are pretty similar to the CR2S2. So they both starting off your complement. And then from here on out, it's pretty similar. So I would even call lectin and classical the same thing in some ways. They're just two flavors of the same thing, whereas alternative is truly a little different. I think my computer wants to crash. I want to crash too. I think I broke it. Wow, it crashed. It crashed. My website crashed. Isn't that crazy? But again, as I was saying, alternative and classical, very similar. I think my core temperature is really high. It's probably gonna die. But let's move on. Let's keep going for complement. Let's finish up complement and then go into a little bit of the histology. So which number was complement? Complement was number 17. So we'll go to 17. Yeah, so this one's very just water and C3b, very self-independent with factor D and B. Whereas this one requires C1. This one follows the normal sort of, that's why we call it classical, right? 1 through 9. 1 starts with 1, then it gets 2, and then it gets 3, right? But as you can see here, C4 becomes C4b, so it steals the C4b, steals the C2a, and then you get that, steals the C3b, and then you get this C4b2, 3b, so 2, 3, 4. uses C1 and it gets 2, 3, 4. This one doesn't use C1. That's the main thing, right? So this one just 3. This one does 1. This one starts at 2. So 2, 3, 4, and then you get 5. And then after that, 5. 5B will start your 5 through 9. And then start your MAC. So then 5 and 3 are really key because 5 is going to form the MAC and 3 is going to get your opsonization. That's like essentially the big thing. And 5A and 3A are both chemokines and inflammatory cytokines in and of themselves. There are some inhibitions that they want us to know. I really don't know if I should be spending time on S protein cluster and factor J. It's all too much. I think, was that CD59? That's the one we wanted to see, I think, 59. Let's remember that, CD59 and DAF. In our non-immune hemolytic anemia. 55 was DAF and 59. Oh, they have 59. See that? 59. 59 in our complement. Right here. CD59. Right there. So CD59 blocks the MAC, and DAF blocks 3B. So that helps out actually quite a bit when we're looking at the red blood cell, right? That's what it protects it. That protects the red blood cell from C3b. This guy protects it from C5 and lysis, reactive lysis. Makes sense, right? C5 lysis, of course. Okay, so that is the finish for complement. So we just finished this, and that. That's quite a lot. So I would normally go on to do the immune system and lymphocytes start. But since tomorrow I have an exam on lymphoid histology, I think we should probably jump to lymphoid real quick. Lymphoid, which is 003. And this should be pretty quick. And I'll bring up the lecture as well as I review it. But lymphoid tissues, you have a primary and secondary. Primary is where the blood cells develop, so that would be thymus and your bone marrow. So we're going to have to know what thymus looks like, but essentially what I found out is in all of these areas, right, thymus, malt, spleen, lymph node, they all have what looks like a lymph nodule. Well, I guess thymus doesn't. The rest of them do. Thymus, essentially, there is layers, though, in the sense that there is an outer layer and an inner layer. Medulla for positive selection and cortex for negative selection for T cells. And there's a variety of thymic epithelia cells inside of the thymus that help you to identify good T cells and train good T cells. So towards the cortex, you'll have more positive checking for positive selection. So what happens is the cells will they'll start in the medulla and they're trying to get out. So that's why you have the nurse cells and the Hassel's corpuscles that are training the T cells. And then once they graduate from positive selection, they're trying to get out to negative selection, and the cortex medulla interface cells will be checking whether they passed. If they pass, they go on to negative selection over here. We're going to go through T cell development, so we'll be back to this shortly. But outside of the primary and outside of the bone, all of the lymphoid tissues seem to have a nodular sort of structure. So where you have the quiescent B cells it can be either inactivated or activated, right? So primary is inactive, secondary is activated. Where you have a germinal center where the B cells will start to go towards the center and start their big training. Right. So the classic, I guess, secondary lymph tissue is lymph node, which includes, I mean, similarly to how this has so many epithelial cells, you have your own here. There's your interdigitating dendritics, which are important for MHC libraries. This is how you get the, I guess it's different than follicular dendritic, which we talk about a little bit later too. But they will help you develop better B cells. And lymph nodes are made with a lot of type 3 collagen, apparently. Lymph nodes have a capsule. So they don't have an epithelium, but they do have a capsule. So we can look at that in the images later. The cortex, outside you have the B cells, and then towards the middle you'll have more T cells and your dendritic cells. And the structure of it is that lymph will enter from the cortex area and it will go towards the medulla and out from there. And then all the blood comes in and out through the medulla. So a little bit different, right? Lymph out to in, blood is only on the inside, really. So you had to go to the medulla in order to leave or enter the lymph node from the blood, at least. So here we can see that, right? So right there, the lymph leaves, the blood comes in. The only place that the lymph comes in is the cortex. So that's a lymph node. So the next one that looks pretty similar, I guess, would be your malt, which doesn't have the same capsule sort of look as a lymph node. Lymph nodes are normally in fat, apparently. And it has the lymph vessels. These don't. But you'll just see them. Malt is commonly seen. Your Pyrus patches are seen in the ileum. But you'll also see malt in the tonsils. And so the tonsils are pretty important for our exam as well. You'll have the palatine tonsils with deep crypts, and they'll have a epithelium that's stratified squamous, because palatine tonsils are in the back of your throat, and actually no, that's pharyngeal. Yeah, so they'll be pretty strong though, palates. The palate in the sort of the top of your mouth. Lingual tonsils are stratified and keratinizing, but the main thing that separates lingual tonsil is you'll see the tongue muscles and fat. Pharyngeal is very special because you'll see the lung epithelium on it because it's so close to the tongue. So again, palatine, deep crypts, lingual muscles, and pharyngeal respiratory epithelium. Appendix, Peyer's patches, you'll have a ton of malt as well. I didn't talk about tertiary lymphoid tissues, but tertiary lymphoid tissue is just any site of inflammation. It's not a real tissue type as much as it's just an infiltrate of lymphoid cells into an area of the body. The spleen. So the spleen, I would say in some ways, looks a little bit like the liver in the sense that it has the sinusoids. However, it looks pretty different because it has two colors going on. There's most of it is your red pulp. So red pulp is includes your splenic cords and a lot of storage of red blood cells and granulocytes. The liver doesn't have. The liver is very uniform, so there's no distinction between red and white pulp. So the white pulp is where you have all your immune cells hanging out. So that's like the basics of lymphoid histology. I'm going to pull up these slides because having the pictures from Dr. Denham is kind of key for doing well on this. Yeah, let's take a look, right? This germinal center right here, and that's the mantle. So that's what a thymus looks like. I think the closest thing we might confuse thymus with is maybe salivary gland because it's lobulated, but then you look a little closer, it really doesn't look like that. So that's thymus. And one of the big things they were talking about in thymus is these big guys over here, these big cells right there, which are the Hassel's corpuscles. That's what these big guys are. Which are these keratinized sort of structures. I think I might have switched the medulla for the medulla is negative selection, and the cortex is positive. Yeah, that's what I thought. I think I swapped the cortex and medulla. That's kind of annoying. Wow. Don't forget the subcapsular. Those are like, I guess they're sort of similar to, in the brain, you have the, I think they're called I think the astrocytes. It's not microglia, it's not oligodendrocytes. I think it's astrocytes, which help form the blood-brain barrier. I think similarly, the subcapsular perivascular makes that thymic barrier. Again, Hassel's corpuscles. So that's a big teller for thymus. Wow, lymph nodes. Okay. Yeah, that's the look of the lymph nodes. So lymph going in from here on the outside and then exiting here versus blood coming in and out through the medulla. All right, there's capsule, cortex. It's good to have some images too. So let's take a look at that. Just the capsule. It's not an epithelium, but it is sort of a capsule, and has a sinus, as an empty space right there, which we're going to have to look for as well. As a medulla, probably harder for me to look at, but there should be a lot of blood vessels going through there. And the hilum. Vascular anatomy. So these must be the so-called what do you call it? They're at the vessel, but they haven't left yet. Oh man, I can't remember what they're called, but yeah. Medullary sinus, cortical sinus, paracortex. Okay, that's what a follicular dendritic cell looks like. That's the germinal center one, but they're pretty round. Reticular cells are your fibroblasts with collagen type 3. And let's take a look at the malt tonsil. So here's palatine, right? So stratified squamous epithelium and crypts. These weird sort of openings here, which I assume is helpful for surveillance for some reason. Lingual, we can see the tongue muscles right here, so that's really important. And then see the lymphoid cells here. Pharyngeal tonsil. So here's the stratified squamous, the pseudostratified columnar respiratory with the cilia. And then Pyrus patches, as we can see on the ilium. Appendix, yeah. So spleen is something that I don't know as well as either. So we can take a look. Spleen, you can see red and white pulp actually. So that's all red. White pulp. Okay, so white pulp looks like that, and it's got these periarteriolar sheaths. So that's why the arterioles look thicker. So we got to remember that too. Those are the pals. A lot of sinusoids. And apparently there's a lot of macrophages inside of the sinusoids. So got to pay attention to that too. I think if I go on a high power, I can see that. So these are just infiltrates. Okay, so I'm going to take some time now and review the images from our pathology, our histology practical. So here's all 30. We can look at liver. See the sinusoids. We don't see a red or white pulp, no lymphoid. Everything's very uniform. That's a central vein apparently. So I feel pretty confident about liver. Salivary. So you might say thymus and you might say pancreas, but it's not thymus because we can see glands, and it's not pancreas because here's a mucus cell. See that? That's mucus. I don't know what that's pointing at, but yeah, these are mucus cells, and this right here is serous. So if you have mucus and serous together, it has to be salivary. Also no islets, right? Thymus. Here's a thymus. So it looks pretty classic to what we were seeing earlier. And if you look closely, there's no, unlike the salivary here, which is also lobulated, you don't see these circles. Instead, it's all just lymphoid cells. And there are these corpuscles, the Hassel's corpuscles. These keratinized little big guys here, which are not found over here. That's how you find thymus. Next we have ganglion. I didn't get a good photo, but yeah, this is the fried egg ganglion. Look, big nerves, big neurons. Some of the biggest guys out there. And there's a little bit of nerve over there with the zigzag pattern. Anorectal junction. So I don't think I got a good shot of it, but essentially what happened is we had this colonic mucosa, and then all of a sudden we had this stratified squamous, which obviously means we went from colon to skin, pretty much. So well, colon to mucosa and then to skin, right? So that's very clearly the butthole. Cardiac muscle is actually really easy for me now. There's these spaces in between them, whereas skeletal is very, very straight. You don't see these wavy sort of things going on. And also, you see some of these, you can see a line right there. That's the striations, so called, and then the nuclei is very central, not pushed out, and very sort of tubular, irregular but tubular still. Pancreas. Pancreas, you might say, is thymus, or you might say it's salivary, but you look at it and you see no mucus glands at all. No mucus, only serous all over. There's also some vasculature, there's some ducts and everything as well. But I don't care about that. What I care about is the islets. That's an islet. Brighter staining, not as red, sort of paler. And it's a ball, like a disc, right, of our pancreatic cells. All right, thick skin. Oh, we can do this in our sleep, right? Very thick layer of just keratin. Spleen. Spleen, we were talking about earlier. We can compare it to our liver. So liver, sinusoids, but very uniform, versus spleen, which is honestly not too similar to liver if you think about it. But we can tell that this is our so-called white pulp right here. These are our white pulps. These sort of lymphoid aggregates with these PALs, these periarteriolar sheaths. And then the rest of this is red pulp. It's not really white. It's more blue, but yeah, that's white cells pulp. GE junction. So yeah, this is a good shot of us switching from stratified squamous and then moving over all of a sudden to this sort of flat. So as we were saying, she was saying this is flat. So it could either be colon or it could be stomach. It couldn't be small intestine, right? Because small intestine is not flat. But yeah, this is more of the esophagus, which we'll find out a little bit later. But that's muscle. But here is where they zoomed in on the foveola here. And you can see parietal cells. Apparently, that's parietal. That's chief. I can't really tell the difference. But if I see this, and I don't think this is a colon crypt, that's GE. Lymph node. Okay, cool. So, a lot of lymphoid, we can tell. So many nuclei. The edge, we can't really see a capsule. But you can see, you sort of see a capsule here, I think. I would call that a capsule. And then all of this is lymphoid. Medullary cords it has. It's honestly a little bit hard for me to see it sometimes. I don't think I see the subcapsular space as much. Maybe a little there, little here. Maybe that is the subcapsular space right there. No epithelium, right, as we've talked about. So, lymph node. Muscular artery. This one I've spent a lot of time looking at, so I can tell the line is right here. If you drew a line right there, you would go from elastic right here, all of a sudden to muscular over here, smooth muscle. Developing bone. So actually this one I almost said was red marrow because from here it just looks like red marrow and bone. But actually, if you were to look at it like that, there's red marrow, there's cartilage, chondrocytes right there. So it's transition. If there's a transition, that's developing. I can compare all the tonsils a little bit later, but here's this. If I immediately saw this, I would probably say It is either spleen, but probably not spleen, right? Because it's so uniformly purpley like that. But you really have to look on the edge. I would maybe say pharyngeal. Sorry, not pharyngeal. I would maybe say palatine because of this groove. But if you look close, you see the cilia. So that's for sure pharyngeal. Cerebrum, there was a wider shot, but I didn't get it. But technically, you have the folds, and you can see all of the sort of the brain structure. But these are just the neurons. You could probably tell these are neurons, with how uniform and spaced out they are. Palatine tonsil, here we go. So for palatine, not only does it have these crypts, but it also has like these like reddish areas. It's just so, I don't want to say dirty looking. It's just not uniform. Very not uniform looking. Right. Definitely lymphoid of some sort, right? But if you look over here, eventually if you zoomed in, you would see stratified squamous. And you would not see the cilia, apparently. Gallbladder, super easy. They said wimpy muscular wall, as they said, and then these wavy, very strange mucosa here. Also columnar, if you looked close. So that's pretty interesting. Next is tongue. So that's a tongue. It has squamous mucosa and a lot of muscle around here. That's not lymphoid, so we have to think about that. That's not lymphoid. That's actually your squamous epithelium. So we gotta compare that. But we know that's tongue. We just need to figure out whether it's lingual tonsil. So we should compare the tonsil right now with tongue. So obviously everything else is the same, pretty much, except for this. So how do we compare that with this? Lingual tonsil. You can see it's definitely there's a lot surrounding it. Whereas there's no variation here with that. So. Like this is very clearly just a epithelium, a thick epithelium, and this is very clearly inside of the epithelium, So, tongue and lingual tonsil. Colon. They said to recognize goblet cells, but I'm pretty sure this sort of a pattern is just definitely colon. All of these little guys hanging out in here. So-called crypts. I suppose these are our goblet cells. And it could be the butt, but if you checked everything and you didn't see it, then it could be. This part is small intestine, just because you can tell this is something small intestine, right? Is it duodenum? No, because it doesn't have that thick glandular stuff going on here. And it also doesn't have the lymphoid pair patches. So therefore it's just... Well, I mean, if it's not ileum and it's not duodenum, then it has to be jejunum, right? So it has to be jejunum. Red marrow. Interesting. So this looks a little bit different than the forming bone, right? It still looks different. But you can tell it's bone in here. That's bone, your bony pieces. And then in here is your little marrow. And fat inside of your marrow. So they call this red marrow. They didn't call this yellow marrow. So, interesting. I guess we'll call it red marrow. Vein. We can tell out here because it has... Vein, they didn't tell us this, but it has smooth muscle running straight at you. Like running the length of the vein. whereas muscular artery is running sort of around the vessel. Lip, it has two sides. It has the stratified squamous side, and then it has the mucosal, like sort of a columnar. I don't think I can see it here, but there was a better photo. Accentic stomach. So it's flat, first of all. And then second of all, you can see parietal cell and chief cell. This one actually you can't see. That's parietal, that's chief, yeah. This one you can tell it's either tendon or fibrocartilage. The moment you see a chondrocyte, it's over. It's fibrocartilage. Ileum. Ileum, so small, like small intestine, right? With these, you can tell it's something small intestine. And then, boom. You know, that's Pear's patch. But I think all of these are as well. Very lymphoid, ileum. Choroid plexus. We know this just because it's so unique. But you have to figure out if this is placenta later. But yeah, very unique. Scalp. See the sole, the circles, the holes. That's got to be scalp. Very easy. Pyloric junction. So we should expect to see the gastric mucosa, and then we should expect to see small intestine. So that's gastric, or the probably gastric. This is definitely small intestine, and those are Brunner's glands. Brunner's glands, Brunner's glands. I want to say I can't see the foveola, honestly. I can't see the pyloric part of it. I don't think I got a photo of it. So that's that. All right. I am going to do a little bit of extra practice, but that's pretty much where we are for today. Did that, did coagulation, did red blood cells, did a little bit of anemia, did all of innate, and then tomorrow we're going to go and hit lymphocytes, T cells, B cells, lymph nodes. Oh, we did lymph nodes today. Tolerance. We can do inflammation and hypersensitivity. Then we'll come over to transfusions, do infections, and do neoplasm. So that's actually a lot. But how many did we cover today? Let's see. 2, 5, 19 lectures. That's not quite half. I have a total of 53. But these are going to be a little shorter, perhaps. So, and I have more time tomorrow. So, should be okay all in all. Yeah, that's it for that. So, with that, I'm probably just going to end it there. Yeah, that's it. That's it. That's it. Peace and love.